Today I have the opportunity to present our colorectal screening, which is a baby in its baby phase. And when we are talking about Seychelles that are not similar to other countries, but they are really specific in their characteristics. They have small landmass, their remoteness is there. We have a small population consequently, we'll have a small economic scale. We don't have enough resource to sustain our economy, but at the same time, we are living from excessive importation of goods. And for sure, when we are talking about importation, somewhere there is notion of food insecurities, and we don't have enough skilled workforce. Healthcare system is not so developed. And for example, in the case of Seychelles, we don't have radiotherapy, and we depend heavily on medical tourism. So in the colorectal cancer, in small island developing state, global burden of colorectal cancer was shown that there will be 3 new cases per day. That was back in 2022, and 1 death per day. And it is supposed to be around 5 new cases per day in 2014 and 2 deaths per day. So according to those figures, we see that it's not only a problem of developed country. Colorectal cancer is not a problem of developed country, but also for SIDS. How is the Seychelles? The Seychelles, you see, it's an archipelago of 115 islands in the Indian Ocean. We have a very small population, only 100,000 and something. We have a high GPD, but the health expenditure also is quite expensive. We have achieved already universal health coverage, and the majority of the population is African origin. We have 3 main inhabited islands, which is Mahe, the biggest island, and Pralay, and then Ladig. So according to our Seychelles National Registry of Cancer, our case of cancer have been on the increment for the past 12 years. Those figures that I'm showing for you is figures from 2011 until 2021. And there's a peak of diagnosed case in 2019, reduced slightly due to the pandemic of COVID, but still we are seeing much more cases of cancer, colorectal cancer, compared to all the colorectal cancer diagnosed in Seychelles. So colorectal cancer is the 3rd case of cancer in the cancer diagnosed in the country. With male or female, it's taking the 3rd place. Also, we have the high incidence of age standardized incidence ratio over 35.7 over 100,000 population. And this will increment more in the next year. So our case of cancer will be more and more in the late stage. We have seen this for the past 12 years, and it is still the same until up to date. We have more stage 3 and 4, and some of our cancer could not be staged because they have been diagnosed at postmortem or already in a late stage and was not discussed. So we have to do one thing to stop the hemorrhage of cancer, colorectal cancer in the country. We have to implement a national program for colorectal cancer screening. The aim is for prevention also as an early diagnosis. And the chosen method should be sustainable and accessible to everyone. We are having a free healthcare policy in the country. Everything in the government setting will be charged to the government, and the population will not spend an out-of-pocket expenditure. So our challenge when we are going to implement this colorectal cancer screening is because we have only one hospital in the country, which is localized on Mahe. And this hospital hosts the endoscopic services. So the other island will not have access to endoscopic service unless they are sent to the main hospital of Mahe. We have limited workforce. So we thought that we were ready for this colorectal cancer screening when we opened the program, because at that time we had enough endoscopists. We have all the resources necessary, but along the way, you will see that our resource has diminished. And we, at the time being, I think we have only three doctors who can do endoscopists, two gastroenterologists and one surgeon. So we planned on integrate the program in the daily operation of the health system, and with a very minimal budget as possible. And at the same time, we have to adapt it to the situation, the local situation, because we have a low level of literacy in the elderly population. And we have to adapt it as well to the Seychelles culture. Is it acceptable for them to have screening on this level? Also, we have to fight about the geographic remoteness between islands. We have the island distance from each other, and the population has to take ferry or flights when they are going to enroll in this colorectal cancer screening program. So the Minister of Health herself has decided to call a task force, and we have gathered a few professionals in the clinical settings as well and the public health setting. You see, when you are in a small island like Seychelles, one can do a lot of responsibilities. We have to multitask ourselves. And when this task force was in place, the responsibility was to define the strategy, how is the guideline we are going to implement, which screening tool we are going to use, and the registry creation, all the logistics. We decided that it's better to pilot the colorectal cancer program first, and then upscale it to a larger population. So the evaluation of this colorectal cancer should be per step, and then per cycle. We have defined some key performance indicator, and then as well we would conduct some cost assessment and other evaluation. Also, we don't forget the quality assurance when you are talking about an organized cancer screening. First of all, on the strategy, our recruitment method was through national media, radio announcement. We chose the population of Ladik first, which is a very small island, the third most inhabited island. And then we have done some TV advertisement announcement for Pralam. And also, we decided to split the target population in two batches because we cannot cater for a big intervention. Also, to address the geographical remoteness, we decided to use some qualitative fit tests, which are home kits, to avoid sending sample to the big island of Mahe. Also, the collection of data should be online. At that time, we did not have the health information system in place, so we decided to use a very simple collection data, which is Google. We decided also to address the low level of literacy, so we split the fit kit that was already a ready-made kit in two. We kept the flow test, and then we gave the attendant, the participant, a leaflet and a stool box, also some vial containing some buffer and collection stick. And we decided the testing should be done in the health center, not at home, like indicated by the factory who produce those feed tests. So we decided to include a population of 54 to 60 years from LADIC. As you can see on our chart, plotting the age group of the patient diagnosed with cancer, colorectal cancer. There is a peak at 50 and above age. Less patients are diagnosed below 49 and 30 age. So our objective was not to overload the running of the routine screening in the main island of Mahé. So we decided to take only this 54 to 60 first of all. And later on, when we shifted to a bigger population on the island of Praslin, we have opened a little bit the age group from 45 to 60 years. So those participants should be average risk individuals. The exclusion criteria was a population with first degree relative of Lynch syndrome. Here in Seychelles, we have found that we have quite a considerable number of population with Lynch syndrome. Also, those who have first degree relative to relative diagnosed with colorectal cancer, personal history of colorectal cancer, and symptomatic patient will be definitely referred immediately to the gastroenterologist. In the population census of 2022, our target population on LADIC were 300 potential participants, sorry. On Praslin, there were 1,330 potential participants, and on Mahé, there will be 15,600 participants. In total, we have about 1,700 participants if we are going to do this screening. So our strategy was to adopt an entry test, which is a fit test. We have chosen a fit test, which is a qualitative test. It's a lateral flow test, which is visually seen as positive or negative. And the threshold of detection is up to 15 gram per mils of hemoglobin. The guideline we adopted is the participant will have the fit test, and if it's positive, they will do a colonoscopy, and if it's negative, they will repeat in 2 years. And the colonoscopy, if it's positive, they will be treated. If it's negative, whether the gastroenterologist will decide to repeat in 5 years, the colonoscopy in 5 years, or repeat fit in 2 years. So as I said, it was a voluntary recruitment, and the registry was done with a simple Google form because we did not have the HIS on place. So when we use a Google form, all participants, the main player, will be able to visualize the result from each health center. And therefore, participants with positive fit test will be called on Mahé to do the colonoscopy. So for that, we have to reassign duties to certain professionals, mainly nurses on sites where the health center are. And the budgeting will be mainly the cost of the feed, the leaflet and the media, and the colonoscopy, the transport and IT materials. So result we obtained in August 2023 on the island of La Digue when we opened the colorectal screening in August 2022. We have a very good attendance rate, about 60%. And unfortunately, among this population who responded to our call, there is a massive dropout out of 138, 186, 48 dropped out. And there were about 31 positivity, which is above 20%. The total colonoscopy that we've done was almost the totality of the positive population of fit positive. But then some of them refused to attend colonoscopy. Also, when we are opening in the island of Praland, that was in February 2023, the target population responded, but we had a very low attendance rate at 20%. And the total positivity was still the same, 20% of the total tested. Colonoscopy were not so great because we started to have problems. We accumulated waiting list, and the attendant did not respond to colonoscopy. Most of them refused or did not turn up, and some of them had to be canceled due to some comorbidities. In 2023, December, the participation rate in total on the two islands, Praslin and La Digue, were very low, only 33.49%. And the total positive tests is still remaining around 20%. Those who are referred for colonoscopy was 65 only. And we had canceled colonoscopy and refusal to attend about 6%. And now we have a waiting list of 30%. That was due to lack of gastroenterologists who could perform the colonoscopy. We had only one left who did respond to our colorectal cancer screening. And the rate of detection is still the same, 25%, 0.25%. So our findings were multiple. Like I said, only one, which is consisted of rectal mass. This 1% consists of 0.25%. Polyps, hyperplastic or adenomatous polyps, there was 4. And the rest is secondary findings and normal findings. Normal findings were almost half, and those were the false positive that overloaded our colonoscopy list. So the first evaluation that we have done is identification of the bottleneck. So already we found that we have very low participation rate, so we need to amend our method of recruitment. And also we have a high rate of false positive. Like I said, almost half of the population, the participants who were scoped were false positive. And we have overloading of colonoscopy. And we were querying how to really assess the cost of this colorectal cancer screen. Is it worth it to do it? So we decided to calculate how we are spending to treat those patients who are diagnosed with colorectal cancer. And if we are seeing that all of the patients diagnosed, most of them are stage 3 and 4, And those are the numbers that really income our budget. And when we see the total cost of colorectal cancer treatment per year, which was up to $388 for cases from stage 1 to 4, without us counting the patient who are not staged. And if we are counting the patient who are staged, who are unstaged, sorry, then it will be up to $538. But how much we are spending for the colorectal cancer screening implementation cost and all the materials and the colonoscopy cost, we see here that we spending only 26,000 US dollars. So numbers spoke by themselves that it is worth it to continue the program. And the third evaluation that we decided to do is to optimize the program. If we are having too much false positive, is it due to the fit test entry test? And should we continue to use the same test or compare it to the standard practice, which is a quantitative fit test using a quantifier machine, not only the lateral flow test? And what will be the cost associated to the adoption of the quantitative fit test? So we have some help from our colleague from the University of Oxford, who did some modeling and see how our program will be upscaled or improved. And if we are going to roll out this program on the bigger population of Mahe and target the 15,000 population and above, we have seen that a qualitative fit screening pathway will cost us about $300 per positive fit test. And if it's a negative, it will cost us $10. And if we are going to roll out the quantitative, each pathway, the positive participant with a fit positive test will spend about $318 to $329. And if it's a negative test, we'll spend also the $10 to $21. So you see, the cost is almost the same whichever pathway we choose. But what is really important is when we model it and we have chosen some variable, we play around some variable. For example, the sensitivity. If we adopt a quantifier and choose a lower threshold, which is about 20 microgram per gram of hemoglobin, and we, for example, adopt a uptake rate, a participation rate of 70%, and we choose a middle cost of quantitative because of we have to pay for the kit. And we have seen that there is a tremendous difference between the two pathways. We will save a lot of money by choosing the quantitative tests because we are having a trade-off from the sensitivity to a specificity. Whichever sensitivity we choose up from 20 microgram per gram of hemoglobin to above, the specificity will stay the same at 95%. So for us, as a small island developing state, we are thinking about transitioning to use a fit quantifier when we are going to roll out the screening program in Mahe. This will improve the uptake rate. We hope so. And we have to secure a colonoscopy service by training more gastroenterologists. So that constitutes my talk about today. Thank you very much for listening.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.